Okay, as you know, tonight is dedicated to cancer genetics, and I'll start out, and then my colleague Lucy Side will take over, and then I'll come back again, and Lucy will do the rest of the talk. Can you give me the first slide, Sophie? So what is cancer genetics all about? What are our aims? We try to identify patients at high risk for cancer due to inheritable factors early, so that they can make the appropriate choices throughout their life. We also try to keep them healthy through tailored surveillance or risk-reducing measures. We would like to enable our patient as they go through their life to make the appropriate lifestyle and risk-reducing choices in time. You know, for young women, just to mention a few, family planning, choice of contraceptive, reproductive choices, then risk-reducing measures, especially important for young people who have a diagnosis of cancer, and we'll give you an example later on in the talk. Shaping treatment choices of newly diagnosed cancer patients, and that is coming on more and more, basically for all cancers, one has to say, and then give the patients the option to enter clinical trials, such as the BARCODE-1 study that Professor Eels, who's also part of our team, is heading. And then enable the family members, you know, the children, the siblings, their parents, aunts and uncles, to have timely access to genetic counseling and testing. Next one. Now, I think it's very important to point out what you all know, namely that the causes of cancer, be it the sporadic cancer or a cancer with an inheritable background, they are multifactorial. We know that lifestyle plays a big role. The WHO has estimated that we could avoid 40% of cancers if there would be no cigarettes, no alcohol, no obesity, being careful in the sun and having enough exercise. Environmental factors, air pollution plays a big role. Then plastics with estrogen-like properties, then industrial substances, just to give you one example, benzene. Genetic makeup may put patients at risk. You know, the red-haired, freckled, blue-eyed, pale-skinned patients, if they go a lot into the sun, they have a really high melanoma risk. And then inheritance, we think it's about 25, 30%. We have genetic changes that increase the risk only slightly. Some that increase the risk moderately, especially in the field of inheritable breast cancer. We have a number of gene changes that we know increase the risk moderately, and we will bring you an example of that, and then the well-known high-risk cancer predisposition genes. And the polygenic risk scores, this is something very new. Each one of these changes, these SNPs, will only increase or decrease a person's risk only very slightly compared to the average population. Next one. Now, the current testing guidelines, they're based on personal and family history or traits that a patient has. And as you know, all healthcare systems are cash-strapped, and therefore they try to formulate testing guidelines basically with a 10% probability of finding a mutation in one of these genes. What are these? Cancer in 2 or more close relatives, young age at diagnosis, multiple primary tumors in the same individuals, bilateral kidney tumors, for instance, repeated colorectal cancers, then some patterns, because most high-risk cancer predisposition genes have their patterns, like colon, endometrium, and ovarian cancer. for Lynch syndrome or breast and ovarian cancers, you know, the BRCA-associated cancers. Evidence of an autosomal dominant inheritance where you will have multiple affected generations. Evidence of a recessive inheritance where you would have multiple cancers in one generation. Next one. Then for the rarer genes, we have either congenital anomalies or benign lesions, like for P10, we may have macrocephaly. Over 90% of patients with P10 mutations have macrocephaly, or they may have the skin lesions, the tricholaminomas. So there are things that you can recognize and that point toward a certain type of gene. Then specific histologies, about 50% of triple negative breast cancers under 50s are due to a germline mutation in BRCA1. Then specific tumors, 15% of isolated ovarian cancers have a mutation in a moderate to high risk cancer predisposition gene. 20% of isolated pheochromocytomas and 30% of isolated medullary thyroid cancers are due to a pathogenic germline mutation. Next. Now comes the point. With current genetic testing guidelines, and we'll give just one reference here, but there are more of these, we miss at least 50% of actionable cancer gene mutations. Actionable means where we know what the risks are and we have something meaningful to offer to the patient. How could that be? What are the possible reasons why we can't see it in a personal family history? It could be that it's a new mutation and the patient is very young and he hasn't had the associated cancer. It could be that it's a recessive inheritance where the siblings don't have anything and the patient again is too young to show anything. Small families, family rifts, we see that more and more, that they don't know what kind of cancers have occurred. Vagueness, basically, they don't know what was going on. Very frequently misreport the cancer diagnosis, especially abdominal cancers are very often misreported and something else than the family member think, and then adoption. So why did we devise the preventative panel? It covers all the known actionable high and moderate risk genes for the most common cancer predisposition genes. It determines the polygenic risk scores for most cancers, and it enables us with lifestyle and other factors to devise a really personalized risk prediction for that patients, and we will bring an example of that in our talk. Next one. These are the cancer genes, the 83 genes included in our preventative panel. As you might know, we have more in the preventative panel. We have also cardiac genes, hemochromatosis, and some clotting disorders, but tonight, of course, we'll focus on the cancer. The genes that are highlighted in red, these are the ones where we will give you patient examples, what that all means if you find a mutation in that gene. Now, we have tested so far 191 patients. 153 had their whole genome screened, and the preventative panel, 38% received their results. Now just focus on the left-hand side of this graph. We have the higher penetrance cancer genes and the moderate or lower penetrance. We have BRCA1 and 2. BOD1 is a moderate breast cancer risk gene. POLB2 is also a high-risk gene. BRIT1 is a moderate ovarian cancer predisposition genes. We have 2 Lynch syndrome, I think an MSH2 and an MSH6 mutation. HOXB13 is a prostate cancer predisposition syndrome. APC is a high-risk polyposis cancer predisposition gene, but this is a mutation that confers only a moderate risk. We'll talk about that. Von Hippel-Lindau we had once. Fumarate hydratase, which predisposes to kidney cancer, SDHA, and DDX1 is one of the newer leukemia predisposition genes. Now I think my colleague Lucy will take over. And
Yes.
I'll hand over to her.
Thank you, Gabby. So as Gabby said, we've included in the PREVENT panel and in the whole genome screen, in addition to high and moderate penetrance cancer susceptibility genes, the majority of which are inherited in an autosomal dominant way, we've also included polygenic risk scores for the common cancers, and we've shown those here. So breast, prostate, and colorectal cancer, ovarian cancer, kidney cancer, and melanoma. So there are 6 common cancers for which we offer a polygenic risk score as part of both tests. I'm sure many of you are familiar with what a polygenic risk score is. And as Gabby said, it's looking at a number of variants, a bit like a spelling mistake in the genome, which individually do not confer very much of a risk or a very slight risk, but cumulatively may confer a more significant risk, and in particular might help us advise patients about additional screening that we might recommend. The variants that are used to calculate a polygenic risk score are scattered throughout the genome. So they are pretty much individualized to that person, rather than passed down through the family as a dominantly inherited tumor suppressor gene variant might be. So it's a bit more like we sort of compare it to shuffling a pack of cards in a sense. Sophie, next slide, please. And a polygenic risk score will allow us to tell a person where their risk lies on a bell curve, which percentile it lies on, compared to the average risk in the population. So that's what we're able to learn from a polygenic risk score, and we're able to convert that to a relative risk of developing cancer compared to individuals in the general population. And now we're going to show you an example of that, I think, Sophie. Yes, so this is an example of a polygenic risk score that we would see in colorectal cancer. So this person's polygenic risk score would put them on the 11th centile in terms of risk. So their risk would be slightly lower. That patient's risk you can see in red, that's the population risk that you can see in gray, and so their risk may be slightly lower than that in the population. And again, that's illustrated on these curves. So this is the average risk of colorectal cancer in the population, and this is the risk for this individual. And so again, that's illustrated there. And this is a person whose polygenic risk score for bowel cancer would put them on the 99th centile. So again, you can see that compared to the general population, their risk is just over double that. And that's certainly at a level of risk where we would consider offering colonoscopy screening. And again, you can see that illustrated on the curves. So this is the individuals with this polygenic risk score, so on this centile, and their risk of developing colorectal cancer compared to individuals in the general population. So we think that this will mostly have utility in terms of making screening recommendations for patients, but possibly also things like chemo prevention. Next slide, please, Sophie. And again, this is just to illustrate some of the data that we have from the patients that we've tested. This shows patients who've actually had, the red dots of patients who've had colorectal cancer and who've come to us for a test. And you'll see that they are, the majority, not all, fall in the top 20th centile. So, we feel potentially that this is a useful test to help us advise people about their risk and any measures they can take. Next slide, please. And obviously, as well as polygenic risk scores, we're looking at genetic contributors to disease risk, and the contribution of the different genes is different in different cancers. So, for example, in prostate cancer, we think that polygenic risks, so these single nucleotide polymorphisms, these variants that we use to calculate polygenic risk, play a more significant role in prostate cancer risk compared to higher and moderate penetrance genes, which we've shown in this bit of the pie chart. And obviously, a significant proportion does not have a genetic explanation. And I think, so if we've got breast cancer, so again, similarly in breast cancer, where actually the single high and moderate penetrance susceptibility genes play a greater part than prostate cancer, but SNPs obviously also play a significant part. Whereas for ovarian cancer, a single gene variants in high and moderate penetrance genes play more of a part than polygenic risk. So that's really just to illustrate the different contributions of the genetic factors to the various different cancers. Next slide, please. And this is really just to show you what happens if a patient expresses an interest in the PREVENT panel. So we send them some information, and we also collect some data about family history, because again, as Gabby will show you, we do take that into account when we're calculating personalized risk. So once the patient returns that questionnaire, we draw up their family tree, and then they have a meeting with our genetic counselor, Katrina, and that's really to talk to them about the test and the pros and cons of going ahead, and so that then they can make an informed decision about whether or not they want to go forward with the test. If they decide they want to, we give them the consent forms and guidance as to how to fill those in. And if they then decide that they still would like to go ahead, they have another appointment, and blood is taken for testing. And it's shipped to our partners, the laboratory in Spain, in Veritas, and they sequence and analyze. So we use whole exome sequencing in the PREVENT panel, and in addition, they give us an analysis of the polygenic risk scores. This takes around 8 to 10 weeks, and it's sent to us by a secure portal, and we review this with one of us in the consultant genetics team, review this with genetic counselors, and if there are any complex results that need wider discussion, we have an MDT twice a week to go through these. And once that process is complete, we're able to relay the results to the patient. But those patients who have significant findings will have a consultation with either the genetic counselor or with one of us if there's a particularly complex issue. So that's the process and the timelines for the test. Next slide, please, Sophie. And as I said to you earlier, the PREVENT panel takes around 8 to 10 weeks, but for some patients who are affected by cancer and who may need a more rapid test and most usually this request comes from patients with breast cancer who are making surgical decisions after diagnosis, we are able to offer a more rapid test within 15 working days. And that's a test, I think it's Fulgent is the provider, and it's done by TDL. We have used Invitae, who provide a very good rapid breast cancer express panel, but unfortunately we think that they are withdrawing their service from the UK by the middle of this year, so we will need to use the TDL test for that. But yes, we can offer a more rapid test for decision making. Next slide, please. So Gabby's going to talk a little bit about some of the families, just give you some scenarios to illustrate what we've found and its utility.
Okay, thank you very much, Lucy. So this is a young woman who came to see us. She's 34 years old. She has a newly diagnosed breast cancer. It's hormonal receptor positive, and she has just started neoadjuvant chemotherapy. And if you look at the family tree, there is an aunt, a paternal aunt, who had breast cancer at the age of 48. So all in all, a high-risk breast cancer family history pointing to, you know, a high penetrance cancer predisposition gene. And we did find with the rapid test a BRCA2 mutation. And below the pedigree or the reported in the literature reported on many patients approximate lifetime cancer risks. Second, breast cancer anywhere between 50 and 80%, ovarian cancer risk 70 to 25, pancreatic 2 to 7, and melanoma 3 to 5%. Can I have the next slide? Now, as I mentioned initially, we would like to do everything possible to kind of personalize that risk for the patient. And a fantastic tool is this CanRisk online tool developed by the colleagues at the Wellcome Sanger in Cambridge, where you really can determine the breast and ovarian cancer risk of patients due to a number of factors. It includes personal risk factors, and I'll show them later, family history, personal history, genetic test results, polygenic risk score, mammographic density. And CanRisk is designed for use by healthcare professionals to help them communicate better with patients, and you will see how that is, and discuss their breast and ovarian cancer risk. And it is endorsed by NICE, by the National Comprehensive Cancer Network in the US, and by ESMO. Next one. Now, what are the factors that CanRisk takes into account to give you a personalized risk? On the left, you have the breast cancer and the ovarian cancer. You have the family and the personal history. You have the results of the genetic testing, and you see here the genes included, where we have some sensible information about risks, age information or unaffected family members, Ashkenazi ethnic origin, Ashkenazi Jewish origin, that changes the risk. Information on the year of birth to capture the birth cohort, age of menarche, parity, age at first life, birth. Then oral contraception, quite important for ovarian cancer risk. HRT, body mass index, alcohol intake, mammographic density, height. Then whether they had a tubal ligation procedure, endometriosis, and then the polygenic risk scores. Next one. So what I did, based on the example that I showed you with the young lady with the breast cancer and the test result and her aunt, the family structure, the siblings, and all her personal risk factors, I did a CanRisk calculation, and you can see the result here. And I think it's quite useful to see that, because it takes it from year to year until the age of 80. And of course, it's her second breast cancer risk, because she already had breast cancer. And on the right-hand side, you would see the population risk of a woman who had breast cancer, and depending on that age. So the population risk for a second breast cancer would be 24.7, and the patient's risk is 87.7, so a very high risk. Next slide. This is in a graph where you can really see how that is taking off compared to the population risk. And what we usually do, we print out this risk calculation and we enclose it for the patient and the referring doctor, so they have something to go on when they have their discussion what to do next. Next one. These are the estimated ovarian cancer risks, again from 35 to 80. On the right-hand side, you have the population risk of 4.6 and the ovarian cancer risk of 14.6. And just to tell you, this patient in our sample has taken oral contraceptive for 5 to 9 years. Now, you can play with this risk calculation. If you take that factor out, the ovarian cancer risk would be actually almost 23%. So it has quite a significant effect. I just say that you see, you know, how these factors can modulate, you know, the personalized risk. Next one. And this is, again, the graph you see, typically for BRCA2, it starts about to rise very slowly at the age of 40 to 45. Okay, so that's low. That's later than the BRCA1. Now, for this young patient, what's at stake and what does she need to discuss? She's, as I said at the beginning, of her neoadjuvant chemotherapy. So the first thing is treatment related. Of course, she's now eligible for a PARP inhibitor. But the most pressing issue is how to kind of surgically treat her breast cancer. Is she going to opt for breast conserving therapy? And MRIs, of course, because she's so young, and maybe when she's 35, additionally mammography, depending on breast density. Or is she opting, and of course, radiotherapy, or is she opting for a bilateral risk-reducing mastectomy, which would reduce her risk of a second breast cancer by at least conservatively estimated 90%. Then the reproductive options are also very much in the forefront because the patient wants to have a family. So she can undergo egg freezing or before the start of chemotherapy, and she can discuss with her treating physicians the timing of pregnancies. Of course, she will have anti-hormonal therapy and partner testing for BRCA2 mutations, because if homozygous BRCA2 carriers have Fanconi anemia, which is a very, very severe condition. Then the ovarian cancer lifetime risk will come, of course, a bit later. It's not so pressing at the moment. Melanoma lifetime risk is relatively low. We usually say, be careful with the sun and have an annual dermatology review. Now, the pancreatic cancer, as you all know, there are only certain families where we have pancreatic cancers in BRCA2 families. And the International Cancer of the Pancreas Screening Consortium guidelines, they do not recommend pancreatic screening for individuals with a pathogenic BRCA2 mutation, but no family history. They take also, of course, into account that there is no pancreatic surveillance of proven value. And as you know, the EuroPac trial, trial screening is still ongoing. Patients who need the pancreatic surveillance, they will get either MRCP or MRI and endoscopic ultrasound once a year. Next one. And here are the implications for the family who can now all be tested. You remember the patient had a brother, and of course the father can be tested, and there are other family members. For females, we have already discussed what are the options based on their age. Male breast cancer is about 6 to 10% lifetime risk. They can have either be breast aware, or some men opt for a bilateral risk-reducing mastectomy. Prostate cancer lifetime risk is substantial, and we know from earlier trials that these are prostate cancer that needs treatment. So they go on a yearly PSA test from age 30, and they have a lower threshold for biopsies, and they also should have a baseline MRI, and they could also go into research studies. Pancreatic and melanoma I discussed already. Next one. Now, this is a recent publication in the Journal of National Cancer Institute, and the two last authors of this publication, and the first one, in fact, come from the group that developed CanRisk. And what they wanted to do, they wanted to look at the effects of the PRS on breast and ovarian cancer risk in BRCA1 and BRCA2 carriers. So at the top, A is BRCA1 breast cancer risk, B is BRCA1 ovarian cancer risk, C is BRCA2 breast cancer risk, and D is BRCA2 ovarian cancer risk. Now, the gray line in the middle is the average without the knowledge of the PRS. The blue lines are either 5% risk, which is substantially lower than the average, or 95%. And in between are the 10 and 90%. Let's now look, for instance, BRCA1 breast cancer risk. It can be substantially lower, just above 50%, if you have a very low polygenic risk score of 5%. If you have a very high one of 95%, you're almost nearing 80% risk. And the same is the effect is a bit smaller in the BRCA2, but you can also see it has a real modulating effect on the ovarian cancer risks. Now, we wanted to give you an example of a moderate breast cancer risk gene. So there are a number of these: ATM, CHEK2, RAD51D, RAD51C, and there are a number of important points to consider. First of all, family history needs to be considered. And then the other point is that the cancer risks for all these genes, some of them are determined and some of them still need to be determined. Now, here in our example, we have this 45-year-old lady with a BORD1 variant. She has a family history that actually quite fits, you know, a BORD1 mutation with a paternal aunt who had breast cancer at the age of 45 and otherwise nothing else. The reported approximate lifetime risks breast are 25%, which is in the moderate category. Ovarian is still very much under discussion. Is there an increased risk? And if so, how high is it? So one needs to be careful here, and we would recommend, like many other guidelines, I think, at the moment across the world, to have yearly mammograms until the age of 50, and after that, every 2 years. And especially with all these genes, I think it's helpful, especially with the other ones like RAD or ATM or CHEK2, if you don't have the high-risk mutation in CHEK2, to revisit the issue of the associated cancer risk when we have more data in a couple of years' time. Now, sometimes we have a variant in a gene that we know confers a moderately increased breast cancer risk, but if that particular patient has a high-risk family history, and that happens for breast cancer, then we would recommend high-risk breast surveillance and not the moderate one that we recommended here. So, yeah, I think that's what I have to say about the moderate risk genes.
Thank you, Gabby. So as Gabby says, we've talked about higher penetrance genes, and we've talked about polygenic risk scores. And we've talked also about how we can use polygenic risk scores and other factors to modify risk in the context of a high-risk gene such as BRCA1 and BRCA2. And I'm just going to show you a couple of cases of some slightly more unusual genes that we have found. And I think this illustrates another point, which is that the manifestations and the risk are not just gene specific, but they may also be variant specific. So actually the variant that we find in the gene may give us information about risk. So I'm sure that you will be familiar with von Hippel-Lindau syndrome. And we found a variant in a patient who underwent the PREVENT panel. And this patient, this particular variant is a lower penetrance variant, and it's associated with type 2C VHL, which is a risk for pheochromocytoma and paraganglioma, but does not appear to be a significant risk for the other features that we associate with VHL, such as cerebellar hemangioblastomas and kidney cancer. So this patient's results came back, and in fact, at the time we saw the results, they were not fully aware of the family history, and subsequently they looked back at the family history and found out that actually they had a parent who'd had a pheochromocytoma at an earlier age, and in fact that parent had had some genetic testing for other genes that are associated with pheochromocytoma and paraganglioma, and that test had been negative, but that panel that the parent had not included the VHL gene. So we will now be able to offer this individual screening for paraganglioma and pheochromocytoma. So that's a real change in management, but actually we were able to reassure them that they are unlikely to develop the other features of VHL because of this particular variant. We were able to give them a bit more personalized advice. Next slide, please, Sophie. And this is just to talk a little bit about the sort of screening that we offer for patients with VHL mutations who are at risk of pheochromocytoma. Next slide, please. And again, we have found 2 patients who have this particular APC variant. Now, APC causes familial adenomatous polyposis, as Gabby said earlier, and usually we associate that with hundreds or thousands, even thousands of polyps. But this particular variant, which is found more frequently in the Ashkenazi Jewish population, involves codon 1307, and actually that is not a variant that is associated with multiple polyps, but we think it doubles the bowel cancer risk compared to people in the general population. So it is a moderate penetrance variant in a gene that is more usually associated with polyposis. And in fact, this patient, in addition to carrying this APC variant, also had a polygenic risk score for colorectal cancer on the 98th centile. And so we were able to consider offering testing to the wider family for this particular APC variant. But we would also obviously discuss screening on the basis of family history. Next slide, please. So as I've said, this around doubles the risk of colorectal cancers, and we offer carrier screening colonoscopies every 3 to 5 years. Next slide, please. So this is us, and this is what we hope to be able to offer. We have combined experience in cancer genetics of more years than I care to mention. We are very much endeavoring to be patient-centered and innovative in our approach. Next slide, please. And this is just to show you the team. So Gabby and myself and Ros, clinical geneticists. Well, Gabby and Ros have also trained in oncology. I'm primarily a clinical geneticist, but our particular interest is cancer genetics, and our colleague Tessa Humphrey has a particular interest in inherited cardiac disorders. Katrina Williams is our genetic counselor, and Sophie Hicks is our genetic associate. And of course, Lucinda provides admin support, and of course Michael has really driven this project, and we're very grateful for him to that. So I think that's all we've got to say, isn't it? There are some future webinars, and we'll talk about some of the other areas where we're offering testing. And you are very welcome to join us for those, of course. And I hope you found that interesting and useful. And Gabby and I'd be very happy to take any questions or comments.